The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss use of liquid biopsies in pediatric brain tumor diagnosis and treatment. My name is Christine Daly, Program Manager here at the American Brain Tumor Association. I'm delighted to introduce our speaker today, Dr. Amanda Saratzis. Dr. Saratzis is a pediatric neurosurgeon at Ann and Robert H. Lurie Children's Hospital of Chicago and Assistant Professor of Neurological Surgery at Northwestern University Feinberg School of Medicine. Dr. Saratzis completed her medical degree at the University of Illinois at Chicago School of Medicine and residency training in neurosurgery at Georgetown University Hospital in Washington, D.C., where she spent 3 concurrent years investigating pediatric brain tumor molecular biology in the Center for Genetic Medicine Research at Children's National Medical Center. After completing her pediatric neurosurgery fellowship at the Ann and Robert H. Lurie Children's Hospital of Chicago, Dr. Saratzis joined the faculty at Northwestern University and Lurie Children's Hospital, where she cares for children with surgical disorders of the central nervous system and conducts translational pediatric brain tumor research in her laboratory. Dr. Saratzis also serves as surgical lead at Lurie Children's for a number of surgery-based clinical trials for pediatric brain tumors. Dr. Saratzis is the recipient of multiple awards for her research, including the AANS-CNS Joint Section on Pediatric Neurological Surgery Kenneth Shulman Award, Louise Eisenhart Award, and Top Basic Science Award, and the Bagan Family Fellowship Young Clinician Investigator Award. In 2015, Dr. Saratzis was named a KL2 Scholar by the Northwestern University Clinical and Translational Sciences Institute, and her laboratory research is funded in part by an NIH-9's mentored Clinical Scientist Research Career Development Award. Thank you for joining us, Dr. Saratzis. You may now begin your presentation.
Well, thank you, Christine, and to everyone at the ABTA for this fantastic opportunity to discuss the role of liquid biopsy in the management and diagnosis of pediatric brain tumors. It's an absolute pleasure to be here with you today, and I look forward to the discussion and questions after my lecture here. So again, today I'm going to be speaking to you about the use of liquid biopsy in pediatric brain tumor diagnosis and treatment response. I have no disclosures. So an overview of our discussion today, I'm first going to give you a little bit of background information on pediatric brain tumors and why they pose a unique clinical challenge for us, specifically because of their distinct tumor biology, their arising in the developing central nervous system, and really the clinical challenge of managing recurrent and treatment-resistant disease. I then want to talk to you a little bit about the important recent scientific advances that really have reframed our diagnostic and treatment approaches for pediatric brain tumors. And these include the identification of tumor molecular subtypes that are both biologically and clinically relevant, and how this has really developed a paradigm shift in the way that we manage and diagnose these tumors. And then lastly, I'm going to be discussing the emerging role for liquid biopsy in pediatric brain tumor diagnosis and management, and how this plays a role potentially in molecular diagnosis, stratification to subtype-specific therapies, and hopefully in the future, longitudinal management of these terrible diseases. So pediatric brain tumors are the most common solid tumors of childhood. The incidence in the United States alone is 5.42 per 100,000 children. This amounts to approximately 4,600 new cases diagnosed annually. Despite this relatively small number of diagnoses, this is the leading cause of cancer death in children. Largely, this has been due to difficulty with advancing our biological understanding of the biology of these tumors due to poor access to tissue for study. And really, despite multiple clinical trials and a lot of laboratory effort, there's really been no change in outcome or overall survival for many of these histologic diagnoses in over 20 years. This is a snapshot of the distribution of different histologic subtypes of pediatric brain tumors as they exist in the United States. You can see the large proportion of these are gliomas, but also a large section of embryonal tumors. And I'm going to be talking a little bit about the molecular biology of these most common or most prevalent pediatric brain tumors today, and how liquid biopsy can potentially play a role in diagnosis and treatment for these diseases. So as I alluded to, pediatric brain tumor treatment is really a formidable challenge. This is in large part due to historical limited understanding of tumor biology. Historically, those who were diagnosing and treating these diseases had this false assumption that pediatric brain tumors had similar biology to adult brain tumors because they looked similar histologically under the microscope. But unfortunately, treatments that were slightly more effective in adults showed really poor efficacy in kids. And this was in part because the biology of the developing central nervous system is different than that of the adult central nervous system, limiting certain agents, different types of treatments that are available to kids, but also because the molecular biology is not the same. And this really hindered our ability to make advances in the outcomes for these kids. In addition, there's a disproportionate amount of funding for pediatric cancer research and a diminished relative access to specimens for molecular study of pediatric brain tumors relative to adult brain tumors. So kind of these formidable challenges or obstacles to advancing our scientific understanding really mandated a paradigm shift in the way that we approach the study and treatment of pediatric brain tumors. And this paradigm shift really has happened over the last 5 to 10 years in our discipline. There have been some really exciting recent advances in our surgical ability and imaging techniques to really help us improve access to clinical specimens safely and use these clinical specimens for molecular study. There's been the development of very important research consortia for specimen and data sharing, which has really increased access to this information about the biology of these tumors. And there's also been the advent of improved computing technology and next generation sequencing techniques that allow an advanced bioinformatics approach to these more prevalent specimens and kind of sharing across these different platforms throughout the world, which have amassed a large amount of data that has helped us really delve into the molecular genetics of these tumors. And as a result of this, over the last 5 years, we've been able to discover significant molecular subgroups of the main forms of pediatric brain tumors that we treat in the clinic. So I'd like to tell you a little bit more about that before we proceed into a discussion of how liquid biopsy can potentially play a role in helping us learn more about these tumors and treating them better. So medulloblastoma is a type of tumor that accounts for 1/3 of pediatric brain tumors. This is a malignant embryonal tumor that arises most typically in the posterior fossa or cerebellum and can affect infants, young children, and young adults. Overall survival is 70 to 80%, but treatment really depends on the molecular subtype and the extent of tumor resection. And there's been a lot of molecular analysis that has shown us that there are actually distinct subgroups with very significant clinical implications in this disease. As a result of significant work by many folks throughout North America and Europe, we've discovered that there are 4 genetic subtypes of medulloblastoma. These include the Wnt, sonic hedgehog, group 3, and group 4 subtypes. And these are characterized by different genetic abnormalities and findings and mutations. But what's more important is that these are also characterized by different clinical features in terms of the gender that they affect, the age distribution in whom they are diagnosed, the way that the histology looks under the microscope, the likelihood for the tumor to metastasize or spread throughout the central nervous system, and the overall survival of these patients. So being able to know this molecular subtype and stratify patients to therapy is paramount to being able to diagnose them and manage them appropriately. And this slide just shows a summary of some of the genetic abnormalities, which include chromosomal losses or gains or duplications, different driver genes that are behind some of the tumor genesis in these different subtypes, different gene expression signatures, and different models of disease that we use to help us understand and treat these tumors. We have similar findings in ependymoma, which is the 3rd most common pediatric CNS malignancy, accounting for about 12% of brain tumors in children under 18 and 30% of brain tumors in children under 3. Ependymoma is a very challenging disease, resulting in greater than 50% mortality despite maximal treatment. And part of the challenge is that histologic subtype and grading is very challenging. Often these tumors of different levels of aggression clinically look very similar under the microscope. And so again, this role of molecular diagnosis and molecular analysis of tissue derived from a large cohort of children has allowed us to achieve understanding of these molecular subtypes that help us treat them better. And here's a nice summary of these subtypes. As we've learned, ependymomas that arise in the spine are different from those that arise in the posterior fossa and those that arise in the supratentorial compartment. And this chart really clearly shows that even within these different anatomic compartments, there are different molecular subgroups that have different pathological features upon microscopic investigation. They have different genetics and oncogenic drivers. They occur again in different locations. They affect children or adults of different ages and genders, and most importantly, they have different overall survival characteristics, some being much more aggressive than others. So this data really helps us prognosticate and allocate or stratify patients to the appropriate therapy so that we can treat their specific disease. And lastly, high-grade glioma accounts for about 1/5 of pediatric gliomas, which account for about 50% of all pediatric brain tumors. I like to focus on high-grade glioma today because this is a disease that I study in my lab because it is the most common cause of cancer death in children. High-grade glioma has the highest mortality of all pediatric solid tumors with a less than 20% overall survival at 5 years. For children that are diagnosed with some high-grade and brainstem gliomas, nearly all children succumb to their disease, often within 2 years from diagnosis. And for this particular disease, there's really been no significant change in outcomes in over 35 years of a lot of laboratory and clinical effort and clinical trials. Now again, this is a theme that there's a characteristic radiographic and histologic appearance, looks very similar to adult tumors under the microscope. But what we learned over the last few years is that they couldn't be more molecularly distinct. And they're distinct both genetically and by tumor location. Very important discoveries were made by two simultaneous groups in 2012 that published the detection of a heterozygous somatic missense mutation in 2 different isoforms of a histone H3 protein. This one is replication independent and one is replication dependent. And this mutation occurs in a critical location along the amino acid sequence of these histone proteins. Slightly different variations of these mutations occur depending on the location of the tumor. In brainstem and midline diffuse midline gliomas, we see up to 80% of a mutation known as H3K27M. In supratentorial high-grade gliomas, we see a mutation known as G34V or R in up to 50%. And what's important about these is, again, like with medulloblastoma and ependymoma, the presence or absence of these mutations portend a very different clinical outcome for these children. These are clinically distinct subgroups of patients that harbor these mutations, that have a poorer overall response to therapy, poorer overall survival, and they tend to occur in younger patients. Now, some of the work that I have done in the lab and work that others have subsequently done really across the discipline has shown that the mutation, when it occurs in these gliomas, causes these tumors to be very molecular distinct. We and others have shown that in the presence of this H3K27M mutation, there are distinct protein and gene expression profiles that activate different types of signaling pathways that make these tumors much more aggressive and likely to spread. We've also found distinct DNA methylation profiles, again, signaling that in the presence of this mutation, there's a change in the way that the regulation of gene expression is being controlled. And again, as I alluded to, these different mutations tend to occur in different locations at different frequencies throughout the brain, meaning that in the supratentorial hemispheres, we see the G34V or R mutation, but in those midline structures, the thalamus, the midbrain, the pons, we see the K27M mutation. And this has really important consequences for tumor biology. So I hope I've convinced you thus far that pediatric brain tumor molecular biology matters. There exist molecular subgroups of the most common tumor types that we encounter in our clinical practice. These have different associated biology. They have different response to therapeutic agents and different modalities of therapy, such as radiation versus chemotherapy, and they have different clinical features and outcomes. So it's paramount that we know and understand this molecular biology as we move towards treating these children. So again, there's this really crucial clinical need to accurately and efficiently identify tumor molecular biology to confirm a diagnosis, to stratify different subgroups, and also to improve our understanding of these tumors, to reveal novel or specific molecular features which could help us develop new treatments, understand new therapeutic targets, or monitor response to therapy over time. This molecular biology, or the knowledge of the molecular characteristics of pediatric brain tumors, and in fact brain tumors in general, has led the World Health Organization for the first time to advocate for molecular diagnostics in the diagnosis or the delineation of a tumor occurring in the brain. This was published by the World Health Organization in their most recent classification of tumors of the central nervous system, published in 2016, which, and I quote, "For the first time, the World Health Organization classification of CNS tumors uses molecular parameters in addition to histology to define many tumor entities, formulating a concept for how CNS tumor diagnoses should be structured in the molecular era." And importantly, as such, the World Health Organization presented a major restructuring of the diffuse gliomas, medulloblastomas, and other embryonal tumors, and incorporates new entities that are defined by both histology and molecular features, including for diffuse midline glioma, that H3K27M mutation that I told you a little bit about. So I hope that I've given you the impression of how very important having this molecular diagnostic information is to us as clinicians, so much so that the World Health Organization mandates it moving forward as we manage these patients. And so what do we do with this information, both as clinicians and as researchers that are investigating how to improve outcomes and understanding of these tumors? Well, we really are moving towards a new approach, a really molecular diagnostic approach for targeted therapy for pediatric brain tumors. So when I have a child that has, for example, in this MRI image, I show a diffuse intrinsic pontine glioma, we'll go in and do a stereotactic biopsy for both histologic and molecular diagnosis. Take those cells to the lab, culture them on the bench, be able to study the molecular biology and the sequencing of both the original tumor tissue as well as the cells. We're able to identify new therapeutic targets and molecular characteristics as a result of this sequencing. We're able to inject these cells into mice and study how they develop tumors with or without certain genes that we can knock in or knock out or target based on some of that next generation sequencing data, develop novel therapeutic targets, deliver new therapeutic agents, and then really bring that back to the bedside in the form of clinical trial. And so this is really the paradigm shift in both the molecular diagnosis and management of pediatric brain tumors with this targeted therapy approach that's really a bedside to bench to bedside therapy or paradigm. And I want to show you some examples of why this is important. That disease type that I mentioned, diffuse midline glioma, which requires that K27M molecular diagnosis, we really have found in the last couple of years the ability to use our knowledge of that mutation and how that affects the biology of the tumor to develop or identify new therapeutic agents. One of the things that we've learned about this K27M mutation is that it affects the way that different transcriptional regulators affect the way genes are expressed throughout the entire genome. And so what we've been able to do is identify different drugs, different pharmacological agents that can affect these different transcriptional machineries to basically shut down either the silencing of genes that we need to be expressed to fight the tumor or the overexpression of genes that are causing the tumor to be formed. And so we do that with different types of therapeutic compounds, such as targeting this particular enzyme as part of the polycomb repressor complex 2, EZH2, or we have a way to pharmacologically target this demethylation process with a different type of agent. And the point here is not to get too nuanced into the epigenetics, but to show you that the knowledge of the presence of this mutation allows us to be able to more effectively use the appropriate compounds to treat these tumors. Our group also found another potential therapeutic target using this very same approach, showing that BET bromodomain inhibition suppresses tumorigenic gene expression in these K27M mutant tumors. And this data is actually the basis for a novel clinical trial that we're opening up for high-grade and diffuse midline gliomas at our institution here at Lurie Children's within the coming year. So again, the take-home message is that knowledge of the molecular biology of these tumors, both at diagnosis and over time, is of paramount importance to our ability to stratify them to the appropriate therapies. So how do we approach that molecular analysis? What do? Well, we can use tissue. And as I referenced a little bit earlier in a few slides prior, we can do this with tissue, and that's really the standard of care right now. Either via biopsy or at the time of tumor resection, we can take tissue to the lab, we can send it to our pathologists, we can do molecular screens and deep sequencing, and we can get a panel of the molecular characteristics of the tumors that we're managing. Then we discuss that as a discipline, a multidisciplinary tumor board with oncologists and various surgeons and others on our teams, and decide how to treat these children moving forward. But there's some limitations to the use of brain tumor tissue. For example, sampling error. We know that there's intertumoral heterogeneity in these specimens, and this becomes most important when we're taking very small stereotactic biopsies where we're only getting a little piece of the tumor, and we're really hanging our hat on the biology that we get from that sample, and perhaps that sample isn't representative of the total molecular biology of the tumor itself. Also, if we want to do longitudinal analysis to see how a child is responding to the therapy, particularly in cases such as diffuse midline gliomas where we can't resect or remove the entire tumor surgically, that would require multiple cranial procedures. It would require multiple biopsies. And, there's associated morbidity with these repeat surgical procedures. Another place where brain tissue kind of fails us, or the need to do molecular analysis using tissue alone really fails us, is in the case of MR occult disease. And what I mean by this is, there are often children that might have disease recurrence that we can't see yet on an MRI scan, or perhaps disease recurrence versus treatment response is very difficult for us as clinicians to tease apart, particularly in the setting of radiation necrosis. And so what we really need in those instances is often to go back and take another specimen, because we just can't tell if the tumor is back or not and if the child needs different therapy. And again, that requires another surgery, it's additional morbidity. And so really, there's a need for another approach, a less invasive and more reliable approach. And this is where tumor biomarker detection via liquid biopsy comes into play. Tumor-derived biomarkers have been shown to potentially reflect brain tumor biology. And these biomarkers can be anything from proteins, nucleic acids such as DNA, RNA, extracellular vesicles that are circulating and carrying biological information about the tumors, or even tumor cells themselves that are circulating perhaps in the CSF. Now, these circulating biomarkers can be detected in more clinically accessible specimens than, let's say, a deep-seated non-resectable brain tumor. So this obviates the need for multiple cranial procedures. These biomarkers can be found in plasma and serum, in urine, in platelets derived from blood, or in cerebrospinal fluid. So you can imagine that monitoring these circulating biomarkers through this liquid biopsy approach could potentially be beneficial, or in fact superior, to repeated tissue analysis for molecular diagnostics and monitoring response to therapy. And the ways in which it could potentially be superior is that it circumvents sampling error that's inherent in multiple tissue specimens. It obviates the need for repeated invasive surgical procedures, and it could potentially facilitate longitudinal monitoring of tumor biology in response to these targeted treatments that we're now learning really play a role in our management of these tumors. So I'd like to give you some examples of where we have shown that liquid biopsy is indeed possible in pediatric brain tumors. This is data that came out of some of the work that I did in Washington, D.C. with my colleague Javad Nazarian there, where we showed that tumor proteins were in fact detectable in the cerebrospinal fluid from children with brain tumors. We showed that there were specific proteins that were present in that spinal fluid compared to control spinal fluid from children that did not harbor brain tumors, and that this difference in expression was statistically significant. We also found that we could go back to the original tumor tissue, and indeed these were proteins that were overexpressed in the tissue from these children. We were also able to detect these same proteins in the blood serum and the urine from the same patient. Another way that biomarkers can be detected in CSF is through the detection of nucleic acids. Now, nucleic acids, DNA or RNA, can show us tumor mutations, and there is data in the adult oncology literature, both brain tumors and other types of cancers, that have shown that there are tumor mutations are detectable in CSF from adults with primary and metastatic brain tumors. There's some really beautiful work that's been done on targeted or genome-wide sequencing of cell-free tumor DNA that's circulating in the spinal fluid of these patients. And they've shown that there's a higher likelihood of being able to acquire and sequence that DNA when they acquire CSF that abuts the tumor itself, such as tumors that occur in the ventricular space or tumors that have spread via leptomeningeal metastasis. There's also some really beautiful data that has shown that the amount of cell-free tumor DNA that is detected in the spinal fluid is directly proportionate to disease burden and response to therapy. So you can imagine how over time spinal fluid may be sampled throughout a patient's treatment, and it can be used to monitor treatment response. In fact, one group has shown that they could actually use the detection of DNA to predict metastases of breast cancer in the brain before they could be seen on MRI. So you can imagine how this is really, really of paramount importance if we could potentially diagnose resistance to treatment or recurrence of disease before a patient is developing symptoms or radiographic findings of disease recurrence. This can make a really major impact on both their symptom control and their overall outcome and survival. So given this work that had been done with adult, both primary and metastatic brain tumors, and finding the tumor DNA and related mutations in spinal fluid, my group set to see if these histone H3 mutations, which as I showed you are really important to the diagnosis and management of diffuse midline and high-grade gliomas, are potentially detectable in spinal fluid from children that harbor those diseases. And again, as I mentioned, these diffuse midline high-grade gliomas are a terrible disease. We have no effective treatment. They are the #1 cause of cancer death in children. So we're really motivated to really find a different way to diagnose and treat these kids. As I alluded to, the anatomic location of the diffuse midline tumors, which occur in the brainstem or the thalamus, preclude our ability to remove them. So we're really left with biopsying for diagnosis and then treating children with chemotherapy and radiation. Multiple biopsies pose a risk of neurological deficit, bleeding, or death, and hence being able to sample the CSF for biomarker detection and monitoring is a superior alternative. We also know that there's this high rate of histone H3 mutations, and they may be driving pediatric gliomagenesis. So we felt that this detection of these tumor mutations and their effects over time could potentially have great impact for diagnosis and management. It could even reveal novel therapeutic targets that may change over time with treatment. So we went to an archive of CSF specimens that we actually had on hand from children that we expected to harbor the K27M mutation and those in whom we expected not to find the mutation. And we basically did DNA sequencing to look for the presence of the mutation in the CSF specimen. Here's the experimental design. The CSF that we collected, we extracted the DNA that we could find within those CSF specimens. Then we amplified that DNA to increase the amount that was present to allow us to be able to sequence it. And we used 2 different sequencing approaches depending on the concentration of DNA that we were able to derive from the various CSF specimens that we had on hand. We did find, as others had found, that we could achieve a higher concentration of cell-free tumor DNA when the CSF from which we took from the patients was closer to the tumor. So tumors that either touched the ventricle or reservoirs that were close to where the tumor is located, we were able to extract higher DNA. And those specimens were very easy to sequence with very conventional methods known as polymerase chain reaction for these histone mutations, which I show here. And this is just some validation. These are these are blots that are showing the detection of this DNA in the CSF from one of these children with diffuse intrinsic pontine glioma and the sequencing results that show the mutation there via Sanger sequencing. And then also some negative controls that show the absence of this mutation in tumors that we would not expect to harbor. We used both CSF from these children and matched tumor tissue to prove that indeed these mutations were not present either in tissue or in CSF. So this validated our approach. So in the specimens that had a lower concentration of cell-free DNA, we used some custom primers that actually allowed us to pick up the K27M mutation in 2 additional CSF specimens. So this was very exciting. And overall, this gave us a result of picking up that K27M mutation in 3 of the 5 midline glioma specimens in which we had expected that mutation to be present. We also picked up a G34V mutation in our high-grade supratentorial glioma, which is expected, as I mentioned, in 50% of those cases. So overall, we had a 75% CSF to tissue concordance, meaning we were able to detect the presence of that mutation with a sensitivity of 75% in these specimens. Very importantly, we did not sequence the H3 mutation in any of the CSF from our expected negative controls, giving us 100% specificity for this approach. And here's just that tissue validation data I wanted to show you, where in the specimens in whom we did detect the K27M mutation CSF, it is indeed present in the tissue. And in those where we did not pick it up in the CSF, it was not present in the tissue. So the conclusions from our study, which to date is the first of its kind in any pediatric brain tumor, is that tumor-related mutations are indeed detectable in the spinal fluid from children with brain tumors. Specifically, our cohort was looking only at this H3 mutation in diffuse midline and high-grade gliomas. And we found a reasonable mutation rate that is very similar to what we see in the literature in our practice in dealing with this disease, with a 60% sensitivity overall over all specimens tested and a 100% specificity for this mutation. And again, we were able to find a greater amount of the DNA in CSF that was in close proximity to the tumor tissue. So as a result, we're really concluding and moving forward in additional studies to really push forth this idea that CSF indeed may be considered as a source of clinical H3 K27M mutation. And this can be as an adjunct or potentially longitudinally in lieu of repeated tumor testing. And I think this will become very important for the way that we diagnose these children, the way that we measure their response to some of those epigenetic targeted therapies that I alluded to in some of those busier slides earlier. So I wanted to touch briefly in the time that we have left that there is also data that shows us that biomarkers can be detected in the blood as well. These are all adult studies looking at brain tumor patients, but they found a variety of different types of biomarkers, including proteins, nucleic acids, in a variety of different biosources, and are using these to detect, again, recurrent disease or metastatic spread. So So this is something that we as a group and other colleagues that I work with are looking at in our matched tumor CSF and blood specimens. These are some of the findings that others have found in adult gliomas, that indeed there are glioma-related proteins that can be used to predict or correlate with overall survival. There's differential expression of microRNAs in glioma proteins that may have some clinical predictive value. And there are specific tumor mutations like the H3K27M mutation that our group was able to detect, that other groups looking at adult gliomas have been able to detect in the blood, and have used information about those mutations or the different methylation states of various genes to help them guide both their diagnosis and their measurement of treatment response. So looking ahead, what does all this information show us, and how is this really going to change the way that we manage and treat our patients? Well, I think as a field, we're moving towards integrating molecular diagnostics and hopefully in the future liquid biopsy platforms into all of our clinical practice. I think I've shown you hopefully convincingly that traditional tissue histology and radiographic studies are absolutely important, but of also paramount importance is this molecular analysis. And we're really now trying to look at paired specimens like diagnosis, the tumor tissue, the spinal fluid, the blood, the urine, and then developing these preclinical models of disease, meaning those cell lines, those animal models, so that we can generate models in the lab that recapitulate those molecular profiles, and then we can give them targeted therapies and determine which therapy works best for which molecular profile, so we can then go back to the bedside with this sort of precision medicine approach to treating every specific child for their specific tumor based on this molecular data. And then of course, moving into the future, longitudinally collecting these specimens, collecting a blood sample or a urine sample instead of repeated brain surgeries for these children in order to better analyze and monitor their response to treatment and detect recurrence. We and others in the field are also exploring some really exciting new analytic technologies that are really going to boost our ability to integrate this clinical, histological, tissue, and molecular diagnostic approach. And I've listed some of those technologies here, but some of those that we're working on and others in the field are collaborating on are using a top-down proteomic approach that allows us to look at proteins in the spinal fluid or in the blood from these children and really understand some of the intricacies of the protein structure itself as it relates to some of the molecular genetics of these tumors and how that changes over time. Looking at genomic deposition of histone proteins via ChIP-seq to help us understand how these histone mutations in pediatric glioma are affecting the way the genomic landscape is being regulated and transcribed. Using a really exciting platform called digital droplet PCR, which allows our and other labs to do what I kind of described in our histone H3 CSF study, but on a much grander scale, meaning using smaller specimens with less DNA concentration and having pinpoint precision, the ability to amplify these very, very small amounts of DNA to something that's actually clinically detectable, to the point where we can sequence mutations where perhaps our prior techniques did not allow, and also quantify the amount of mutation in a biospecimen to watch how that changes over time in response to therapy. And then lastly, working with a number of collaborative colleagues and clinicians to really validate these proteogenomic platforms that we're integrating in our laboratory practice to be able to bring that back to the bedside to achieve this precision medicine approach to managing our patients. So in summary, pediatric brain tumors are the #1 cause of pediatric solid tumor death. This is a very formidable challenge in terms of managing and helping these children and really improving the outcomes for our patients. And historically, we've really been stymied by a limited understanding of tumor biology and really poor response to conventional chemotherapies that were tailored or designed for adult disease. But there's been some exciting advances in the last 5 to 10 years in our field that have allowed us to employ new molecular analytic techniques that have really rapidly increased our understanding of the biology of these diseases, that have allowed us to identify tumor molecular subtypes and associated mutations to really understand these diseases, not perhaps as one single entity, but for example, in the case of Medulloblastoma, really 4 different diseases that are very genomically and clinically different from one another. That's allowed us to develop novel targeted therapeutics to treat each of those subtypes more efficiently and more effectively, and then really develop these platforms for using molecular diagnostics in the clinic and being able to use those diagnostics for monitoring response to therapy. And I hope I've convinced you with the work that we and others have done in both pediatric and adult glioma and other types of brain tumors that liquid biopsy for tumor biomarkers is feasible, and it offers a really new and exciting way for us to diagnose, treat, and monitor pediatric brain tumor patients more effectively. So with that, I'd like to thank my colleagues and collaborators, both at Northwestern University, Lurie Children's Hospital, and Children's National Medical Center, who helped me with this work and with whom I generated some of this data over the years. Most notably to our patients and their families who are so selfless with their time and their willingness to donate specimens to our research enterprise to really push our understanding of these diseases forward and help kids better in the future. And of course, the funding sources that allowed my lab to do this work and make these findings possible. So with that, I'd like to take any questions. Thank you.
Thank you, Dr. Saratzis. We will now take questions. If you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. The first question that we have for you, can this liquid biopsy be used for monitoring an atypical meningioma, and is it available now?
So thank you for the question. Certainly, we have only looked specifically at diffuse midline and high-grade gliomas in terms of looking at that one specific mutation. But I believe that for any tumor that harbors characteristic mutational characteristics, this technology could be easily applied. Some of the work that we're now doing with that digital droplet PCR is to do exactly what you're describing, looking at a variety of different types of brain tumors, including meningiomas and others, looking at characteristic mutations that are harbored by those tumors to see if this technology can be used to detect them. So it's a great question. Technology is not there yet, but only because it hasn't been tried. And I think that it's absolutely feasible.
Great, thank you. The next question, is this technique available for benign epidermoid brain tumors that develop in early pregnancy the same week as spina bifida?
That's a really interesting question. And again, the answer is somewhat the same. I think for any type of lesion that has a characteristic mutational phenotype, we could develop primers that would allow us to look for tumor DNA, and if it was there, sequence that tumor DNA for that specific mutation. Certainly it would require at first, developing a platform for that and then determining if there were circulating DNA in the blood or CSF of a woman in her pregnancy. But I could foresee, that technology evolving over the coming years where perhaps people are kind of screened just like we screen amniotic fluid for things like neural tube deficits, as you've alluded to, spina bifida. That could be something of a panel that we kind of screen everybody for via a blood serum or a urine screen.
Thank you. And the next question is, do you have any advice for what people can look for and how to be proactive with treatments?
With treatments, meaning just kind of in general for brain tumors?
Yeah, that seems to be the question, general treatments.
Sure. So I think that's a great question. It's very difficult because what we know from treating children with brain tumors is that children can have a fair amount of disease burden without showing any sort of clinical or neurological signs and symptoms for a very long time, particularly in the case of very slow-growing tumors, because children are very, their brains are very kind of adaptable to pretty significant mass effect before they may show something clinical. And so it's a really great question. I think often when we're talking about monitoring for disease recurrence or relapse or lack of response to therapy, we're looking for the recurrence also of the same symptoms that the child presented with. So if the child initially had headaches or a particular cranial nerve deficit or weakness or imbalance, those would kind of be the symptoms that we would be looking for that would signify to us that indeed something is growing again or the tumor has recurred, that would warrant really prompt evaluation workup. Our goal or our hope is that hopefully within the course of my career, we'll be able to develop this type of technology where we wouldn't have to wait for children to be symptomatic, where we wouldn't even have to wait for us to be able to see recurrent disease on an MRI, where we could maybe at routine regular intervals, such as 6 weeks or 3 months, do a simple blood test or urine test or spinal fluid test to see if these tumor-related proteins or DNA, whatever biomarker proves to be reliable in longitudinal monitoring, could be tested and detected, and then we could treat the child before they would have any symptoms.
Great, thank you. The next question is, how challenging is it to extract cfDNA regarding the amount of material needed? Are there special kits for cfDNA extraction?
So that's a really great question. It's a very technical question. So the short answer is the more DNA that's present in your biospecimen, the easier that it is. Certainly there are kits, there are commercially available kits that allow extraction of DNA, but I think the degree of technical challenge is directly proportionate to the starting material concentration. So in specimens where it's very dilute or there's very little circulating protein or nucleic acid, it's much more challenging than in cases where it's more abundant.
Great. And I think maybe our last question, is liquid biopsy by blood test available now for optic low-grade glioma?
That's a great question. No, it's not, but that's something that actually we are working on, looking at paired optic glioma tumor tissue, spinal fluid, and blood, all from the same patient, to see that if there are relevant tumor biomarkers, specifically proteins or mutations in the DNA, are detectable across those different specimens.
Great, thank you. That is all the time we have for today. Thank you all for joining us, and thanks once again to Dr. Saratzis for her wonderful webinar presentation. Besides our free educational webinars, ABTA has a variety of programs available to help connect patients and caregivers with information and resources to help support them in their brain tumor journey, as well as publications and resources for healthcare professionals. For more information, visit ABTA's website at www.abta.org or call the ABTA Care Line at 1-800-886-2282. Let's pause for just a moment to conclude our webinar recording.